brief summary. What was going on with the patient?
It's an elderly gentleman who came in with a history of end-stage lung cancer, left lower lobe pneumonia. Obviously getting worse. Daughter was at bedside with him along with grandchildren. They were, I guess, making an attempt to comfort him.
And then there was a little bit of family conflict going on.
Yes, there was.
There was a lot of family conflict going on. Okay.
I didn't want to, I did not agree with the do not resuscitate, and so there was a conflict between me and my sister about should he be resuscitated, should he not be resuscitated, who has the final say, because my dad was incoherent or unavailable or whatever you want to call it.
I really don't feel like I handled that very well.
Yeah.
No, I don't.
You were very calm, and
it just seemed like it just made me really flustered having to deal with the patient and have that argument going on over him while I was trying to do that and watching his vital signs drop.
But you were very focused on the patient, which was good. You were worried, about him and taking care of the patient.
You concerned yourself very little with our conversation. You made your focus on our father, which was good.
Yeah. You just have to remember to call for help.
Yeah. You did call for help.
Okay, let's take a look at a few segments here. So you're doing a nice job there of when the family says he's getting a little more confused, you're going right to let me get a little more information. What kinds of concerns would we have with a patient with this history?
I mean, he's end stage, he's a cancer patient. I don't think I have his vital signs going at this point, so right now I'm just trying to get my report was very brief. And so I felt like I was really learning who this patient was right off. Just from my assessment, very little information given. So I didn't know what to expect from him at this point.
Yeah. I guess his, respirations would decrease and his heart rate and pain.
We would want him to be comfortable.
We want him to be comfortable.
Right.
There would be some emotional concerns too, though.
Like I said, we haven't really addressed the DNR paperwork yet. I knew that we talked about it in the report, but I hadn't taken the time to look at that DNR paperwork to see exactly. Was it the original paperwork in the chart? How to go about dealing with that with the daughter that's at bedside.
Yeah. Because that will direct you where you need to do. So I guess that's what we need to find out.
It probably would have helped me in deciding if I needed help or not. Which I think hearing that I had a DNR report is probably what swayed me away from calling for help to begin with. I think having that there, I already knew that calling for help was, he was going to be in this state until he passed on.
But it's not like his help. It's like, you need the help.
Right.
Think about it in terms of how you need the help, how we can support you. Have you ever dealt with a DNR situation before? Yeah. So.
And sometimes what you get in report isn't necessarily the complete truth.
Right.
So that makes me think, just because the nurse gave me that in report, I still need to verify it in the chart and the paperwork.
Yeah, we have to figure out that DNR was it a true advance directive, or was it the hospital's DNR form that was signed?
Right, because, and I never even checked to see if it was signed. So.
Right, we'll have to figure out that piece of it. And you could have had the house supervisor just take a look at the paperwork too.
And that would have been probably a great way to de-escalate the tension between my brother and I, in that you'd say, well, I'm not sure about that. Let's see if we can find it and discuss what it is that the DNR says that we're able to do for your father. And not
Which brings me back to calling for help, because at this point I had no time, to even discuss that with you. I'm watching your father, get worse and worse, and pretty soon he wasn't talking to me anymore, and I'm listening to the argument going across the bed, and I'm trying to, prioritize what I needed to do at this point. And if I would have just called, got an extra set of hands in there, it would have allowed me to focus more on what I needed to do. And
I did think it was great that one time you said you'd put your hand over the mannequin, almost kind of in between this Evans and my space, and it got our attention enough that we turned towards you and you said, "This is not the place to do this, not over your father." And it was like a pause in the entire event.
Well, and from the nurse's perspective, what would you do if you have a contested DNR and you have a patient who is dying, what are you going to do when he stops breathing?
Sitting here calmly in this chair right now, I would have called the physician. At the bedside at this point, I was just, you know, I can't believe I'm having to deal with this argument, and I have this patient that's deteriorating. Now I'm starting to question whether or not the DNR is actually for real or not, whether I need to actually call and, you know, this patient needs to be intubated.
Right.
And it became, you know, a challenge.
Jeremy, since I was out of the room and observing, it seemed like you were really, you know, involved. So did you feel like a part of this?
I felt like this is my
it was
patient.
real?
Mm-hmm.
Wow.
Which I really wanted to leave the bedside so I can take care of this guy, and which I'm surprised, you know, because being said I've never done this before, I'm surprised that I actually felt like this was a patient. You know, I think it helped that he talked to me at the beginning. You know, that helped me to buy into the whole thing, and pretty soon, then when he stopped talking, it was like, oh no, there's a change in.
So this is where it looks like things are changing. What kinds of thoughts do we have when we've got a change in a patient status?
What is that change? What's going on?
Right. And you kind of think like, oh, what do I need to assess more now? You know, where should my focus be?
I felt a strong need to put him on this monitor and find out what, you know, what he looked like beyond what my initial assessment was.
Okay.
He stopped talking to me, and I could see that he's starting to turn a little purple around the lips, and I go, okay, this isn't good.
So when you think about his respiratory status, what would be something you could consider?
Calling respiratory therapy to come down and give him a treatment, or, you know, suctioning. I should. He had a lot of sputum that was coming up. I saw in his, you know, when he was coughing. So I could have suctioned him.
Okay.
Especially since I noticed that his nasal cannula wasn't giving him enough oxygen, and I had bumped that up as high as I could go on that. And
there was a lot going on in a short period of time.
Yeah.
There was.
It was overwhelming watching, so I can't imagine being involved in it. You did a great job.
Needed help.
Okay. So given an opportunity to do this again, you'd call for help?
Yes.
Any other thoughts about what would be?
Well, I think that because you didn't know the status of the DNR and all that kind of stuff, that you didn't have to decide that wasn't something that you had to decide to automatically just, you know, escalate it to, you know, house supervisor or, you know, somebody much higher than yourself to give that burden to them, because it's not in your scope to sort that out. I think, right?
I agree with that. I mean,
that wouldn't be in their scope.
In fact, I think I actually ignored it. I mean, which is not right either. I mean, I completely ignored that part of it, which needed to be addressed, because I mean, eventually it was going to come down on me, you know, whether or not this DNR was appropriate or not. If I choose not to do anything with my patient without having that clarified, you know, ultimately we might have needed to intubate this guy, and I might have waited too long, you know, and so.
So it sounds like clarifying the status sooner would be helpful.
Yes.
Okay. Any other thoughts?
Anything else you could have done for the patient to make him more comfortable?
Considering he was coughing a lot, I could have set him up a little bit more. If he wasn't in any C-spine precautions, I could have definitely set him up. I could have got him a few more pillows, and I mean, really, I mean, ultimately, I should have been making him more comfortable.
Yeah.
Okay.
I needed to check the orders. In fact, I think I told him I was going to check for orders for more pain meds, but I never got to that point.
Because he kept saying pain.
Yeah. Oh, and I noticed that the side rails were down too. So
yes,
maybe be aware of that.
Yeah, the patient safety. That's right. There's so many things. How can you keep track of it all? Wow.
And I think at my point I wasn't too worried because the daughter was on the one side of the bed, but I was definitely leaving my side, going back and forth, and I should have put that rail up while I was, whenever I left that bed.
Okay. Well done.
Very good.
Lots to think about. Let's take a 2-minute break, and we'll go ahead and repeat the scenario. Everybody keep the same roles.
Okay.
All right, and then later on we'll all swap roles with some different scenarios this afternoon. Okay?
Okay.
Great.
All right.